Good morning, everyone. Thank you very much to the brave souls who turned up bright and early this morning for the last day's plenary. So just first off, we'll start with some housekeeping announcements. So wanted to thank the conference gold sponsor, Gilead, and silver sponsor, AbbVie, and also just alert people to 2 lunchtime sessions. There will be one in the discussion space at lunchtime, and the topic is there a difference between safe supply and an ideal OAT? And the session will be discussing the gold standard of OAT. There will also be a second lunchtime session at 12:30 p.m. on addressing gender-based violence against women and people of diverse gender identity and expression who use drugs in rooms B and C. So, on that note, now that we've got the announcements finished, I want to welcome everyone to the plenary session on women who use drugs. So this is the first time that there has been a plenary session dedicated to women who use drugs that centres the voices of women who use drugs and all our diversity, including geographic diversity. So I'm Judy Cheng. I'm the Executive Director of the International Network of People Who Use Drugs. I'm also a woman who uses drugs and have been for over 20 years, and am also a feminist, and so very much see the experience of drug use as a matter of bodily autonomy and agency. So next I'll just turn to my co-chair to introduce herself.
Good morning. Excuse me for my not very good voice this morning. I'd like also to welcome you to this Women in Drug session. I'm so excited. We have worked a lot to get this session together. And my work in the field is as a medical doctor. I don't know if I said my name, Erica Castro. And I work 40 minutes away from here in Lausanne as addiction medicine doctor, and also where we run something that is called the Virtual Clinic, which is a HCV elimination initiative for people who use drugs and alcohol and migrant population. It is a big pleasure to be sharing the session this morning with Judy Shen.
Thanks. So in the first lineup of our speakers, we have an introduction to the Jude Byrne Award, which is in its 2nd year. And the Jude Byrne Award will be introduced by Annie Madden. Annie Madden is currently a part-time project lead at Input, so as a colleague, and also part-time executive director of Harm Reduction Australia. Annie has represented people who use drugs for over 3 decades within Australia and globally.
Good morning, everyone. I'm not going to be using slides as I'm just introducing the award and the recipients for this year, but I did want to take the opportunity to just give you a little bit of background on the Jude Byrne Award for those of you who are not familiar with the award. So, as Judy mentioned, I have been involved in drug user organising for over 30 years, and a lot of that time has been in Australia. And during that time, I had the great pleasure to and privilege to work with Jude Byrne, who was an amazing and very strong drug user activist who was one of the co-founders of the Australian Drug Users Movement way back in sort of 1980, late 80s, early 90s. And she was a mentor of mine, and we worked together for decades in Australia and globally. Jude, in addition to making an enormous contribution to the drug users movement in Australia and founding some of the very first women and drugs programs and services in Australia, particularly doing work that in the late 80s that was really very new then around sort of maternal health and mothers and babies programs in Australia, so that women who use drugs could come into a clinic that was open to them and didn't feel stigmatising, and could have their baby health checks done and just feel valued as women and as mothers. So she was doing that work really early, and in addition to her work in Australia, Jude also was the chair of the INPUD board for some years and was really instrumental in co-founding INPUD as an international network, and worked for many years to ensure INPUD's kind of establishment and ongoing viability. And sadly, Jude passed away in early 2021 after a short illness, and just prior to that she had also been on the board of INSU. And so when Jude passed away, and given all of the amazing work she had done, both for the drug users movement and more broadly in the sector, we, INPUD and INSU, came together to look at developing this award in her name for emerging female leaders, drug user activist leaders. So in 2022, we had the first round of the award, and last year I had the pleasure of introducing this award at the previous INSU conference and the recipients for 2022. One of those recipients is at this conference and has gone on to have amazing opportunities associated with being the recipient of the award. And then it is my pleasure to have this year's recipients here to speak with you today and talk about their experiences and what the award has meant for them. The award is largely a mentorship type award, that it's a 9-month mentorship program, an award prize as well, and also a conference scholarship to this conference, and the ability to network and to sort of build their profiles at an event such as this. So that's a bit of background. We had, like last year, the first year, this year we also had an amazing response to the award. We had over 20 applications, and the application process is quite strenuous, and each applicant has to provide a video and a written application and testimonies and all of that. It's a really, really hard decision to make. There's an amazing panel of women who are activists who help make the decision, but it's always really hard, and we could easily give the award to all of the women that are nominated or nominate. So I just need to say that, because it's, you know, it's hard to put yourself into these processes, but encourage people, if you've been in it before and not received it, do try, keep trying, and if you haven't been in it, give it a go. And yeah, it's an amazing award. I think Jude would be incredibly proud of this award and the work that is going on to be done in her name. So I'll leave it there, and I'll hand over to Judy to introduce our recipients for 2023.
Thanks so much, Annie. So I'm really pleased to introduce Jessica Inez Morales. She's an activist, mother, anti-prohibition feminist, and drug user who's currently living in Guatemala City. And she's also the national focal point for the Latin American and Caribbean network of people who use drugs. Thanks, Jess.
Good morning, everyone. So again, my name is Jessica Morales. I am from Guatemala, Central America. Today, I'm just going to show a couple of pictures of the work that we are doing in Latin America. But first of all, I would like to give thanks to INSU and INPUD for the opportunity to be here today. I would like to thank LAMPUD, the Latin American network of people who uses drugs, and all my peers who are in a continuous fight against the impacts of the war on drugs in our territory. I would also like to thank all those women warriors who are no longer with us and all those victims of this war on drugs. May we continue to honor them and walk with their names and strength as a banner. As we have always said, this is not a war against drugs. This is a war against people who uses drugs. A war against women, sexual diversities, Black and Indigenous communities. Drug policies continues to be a tool used by the system to control and eliminate our communities. Prohibitionist drug policies and stigma continue to be used to maintain an ideal of a woman useful to the patriarchy. The violence that is manifested against women who use drugs is a corrective violence that aims to maintain the idea of an obedient woman and devoted mothers to a system that wishes to maintain a hierarchy of male power. These drug policies also continue to be a tool to control and eliminate Black and Indigenous populations in order to maintain a power based on colonial racism. This is what we in the Global South call policies of death. Guatemala and much of Latin America continues to be a territory that suffers and bleeds the most violent part of this war. Big cartels have infiltrated all areas of government, and it is from this social and political environment that we continue to resist and defend our bodies, our life, and our territory. Our resistance is permanent until there are no more deaths due to this senseless war against us, until there is no more stigma and discrimination against people and women who uses drugs, until there are no more deaths on behalf of this racist and patriarchy system that continues to insist in the exploitation of life. Thank you.
Thank you so much, Jessica, for that really inspiring takedown of the war on drugs and the disproportionate impacts it has on women who use drugs. So next I want to turn to Kira Watson from Scotland. She's a drug harm lead working at the National Health Service.
Thanks, Judy. Hi, my name's Kira Watson and I have come from Scotland, and I'm so honoured to have been selected for this award. It was such a surprise and such a privilege to be involved in this, and I'm so glad to be here. I've just got some slides to go through while I speak, and just also so inspiring to hear Jess and the message that she's sharing. And yeah, so thank you, Jess, for sharing those words. It's great to be on the stage with you. So this first slide, you need to stop going on about drugs because you're going to get a reputation. So I was told this a few years ago by an ex-partner, and I thought, the war on drugs has been affecting my life since I was 6 months old. I've had too many people close to me die after taking drugs, too many people come to harm, too many people be affected by the war on drugs, their lives changed irrevocably. And so I did not listen to that. I spent quite a lot of time writing about drugs as much as I could, sharing information about drugs, making sure people knew where to get information, where to access services, how they could improve their day-to-day. So I spent a long time doing that, and I connected with lots of other people who shared this passion, this commitment to harm reduction. I connected with amazing people working in harm reduction projects across Europe. I'm so grateful to have found these people. They are my family, my wider community. I've learned so much by going to visit other projects to see how they work and to take that learning back to Scotland, to take that best practice, and to take that companionship, that camaraderie. It bolsters the work that I do to know that I have these people who are my network, they are my people who are doing this in other places. So a huge thank you to all of these organisations that have allowed me to come to work with them across Europe, and so many of them led by women. I wouldn't be here without Helena Valenti from Cosmicare, Chris from Cosmicare, Maria from Energy Control, and also the force of nature that is Joanna Canedo from Euro Input. They are all so amazing to work with. I just want to touch on what this award means to me coming from Scotland. So women in Scotland are dying at quite a high rate after taking drugs, and it's something that it's really difficult not to focus on. So women have been disproportionately affected by the war on drugs in Scotland for all different kinds of health determinants, and you can see here the rate at which overdoses for women have been increasing over the last 20 years. So there's been a nearly 500% increase in the last 20 years, and in the last 10 years, an 118% increase. So it's just not good enough that the services in Scotland for the last 20 years have not been designed for women. They've not been supporting women. All the amazing work that Annie was describing that Jude was doing in Australia, it needs to be replicated in Scotland on a huge scale. And I hope that in some way this award can allow the light to be shone on that fact and for me to contribute in some way as well. You can see as well disproportionately the deaths in Scotland have went down for men, but for women they've continued to rise. And just a little spotlight on Scotland as well of why I focused on overdose and death, because Scotland's drug-related death rate is disproportionately high to the extreme. We are 3.5 times the rate of the rest of the UK. Despite living in the same island, the same country. And of course, some of the other countries in this graph may record deaths in a very slightly different way, but not enough to account for such a disproportionate rate there. And so this is why I'm committed to this work, because there is too many people from my community being lost, too many missed opportunities to support people, too many missed opportunities to lead with compassion and love. And I'm really grateful for this award. It's allowed me to get involved with loads of things. One of the things I just wanted to add there is I met Gabor Mate a few weeks ago. It was really cool. But also, I've completely changed my job as well. So there's been lots of funding in Scotland to respond to the drug-related deaths crisis. So I've now taken on a national role to look at overdose prevention, working with the NHS and ambulance service to make sure that people who are affected by overdose have access to naloxone, to clean needles, and I'm really excited to progress in this role. I was once told by another female leader in harm reduction that you can spend a really long time shouting outside windows waiting to be heard, and every so often you get the opportunity to whisper in ears. And I think this is something that this new role will also give me. And I encourage anyone, when you get that opportunity to whisper in ears as well, to take it, because it makes the shouting outside windows so much easier to continue to do. And I just wanted to end on a photo with Jess and I and some comrades from Portugal who are also here in this fight for women who take drugs. Thank you.
Thank you so much, Kira. I love that whispering in ears. And yeah, I just want to finish and conclude the session with just saying like how amazing it has been to be involved in the whole process of the Jude Byrne Award. And I think the critical part of it and the most important piece for me is, being introduced to people such as Jess and Kira and having, these really new, fresh, really important voices, being part of the movement. Thanks.
It is now my pleasure to introduce Professor Nuria Romo Aviles. She is joining us from the University of Granada in Spain, and where she's involved in medical anthropology teaching and develops her research on women and gender studies. She will be sharing this morning with us her expertise on understanding the role of gender in drug use. Thank you.
Thank you very much. Good morning, everyone. I would like to give the thanks to the organizer for to be here. And I would like to give many thanks to this artist, that is Liliana Merizalde from Colombia. It has often been assumed that gender differences in health are inevitable and constant. Like life expectancy, for example, is higher for women than for men, almost everywhere in the world. So, however, the extent of gender difference in life expectancy varies greatly globally and within the same country over the time. So, these geographic variations and rapid change in gender difference in life expectancy illustrate the importance of the social environment where people is living. Women live longer, but with a lower quality of life all around the world, with more chronic problems or health chronic problems. The perception of health of women is worse than that of men, and they go to the health system more often for themselves or for the people they care for. So they are diagnosed more frequently due to discomfort that have to do with their social situation. In relation to drug use or abuse, social and cultural factors can explain people's elections, motivation, why some may be using problematically and others don't. In my opinion, Finberg model is still a useful model to include these different aspects that we can observe in how patriarchy, sex gender difference, or inequalities impact on different levels, generating a more comprehensive perspective in the use or abuse of substances. We refer to doing gender when we use drugs because it is a conceptual framework that understands gender as produced, performed in everyday interaction, rather than something that is natural or innate within women or men or non-binary people. As you maybe know, the basis principle of the model is that drug use are the result of the interaction between drug set and setting. In this presentation, I will think about it with a feminist perspective. In relation with drugs, feminist perspectives in the approach to the drug use show the existence of different patterns of use, abuse, and dependence on substances between men and women or non-binary people. In general, women tend to consume drugs that are illicit and socially accepted to a greater degree than men or boys. Different studies are discussing now the incorporation of young girls into the legal drug use and how at some ages and in some European countries they consume alcohol, tobacco or medicines as tranquilizer in a bigger prevalence than boys. In this respect, I would like to highlight how the increase in alcohol consumption among young women has been the more striking change in drinking culture in Spain in the recent years. The official data show that the prevalence of alcohol consumption was higher in young women than in young men. For example, out of the total number of young people who drank alcohol during the previous month, half of them acknowledged being drinking, and almost half admitting having an episode of intoxication, with the percentage being higher among girls than boys. In the group, for example, of the minors between 14 and 17, 47.1% of the boys and 52% of the girls state that they have been drunk and sometimes of their life. Women and other population like trans people suffer a process of medicalization in different stages of their lives. We have now a strong body of research analyzing it from social science or from feminist studies. Women are prescribed with tranquilizer and sleeping pills to cope with work, with family stress, with premenstrual syndrome, or just with the adjustment of life events such as childbirth or menopause, or for chronic illness like pain. No? The higher prescription and consumption of psychotropic drugs among women can be explained by the complex triangle in which we find ourselves, the bias in the type of prescription, the pressure from the pharmaceutical industry, the analgesic societies, and their interest in medicalizing the different stages of women's lives, and the women themselves, who integrate self-treatment practice into their everyday life to deal with their problems and with their inequalities. No? This type of self-treatments are passed on to younger women and probably transmitted by their mothers. On the other hand, medical doctors, women and men, identify women with a higher necessity for the use of these drugs, and these necessities are in relation with the medical construction of women as anesthetic and with more necessity for medication. I think it can be seen as a way of medicalization of women's distress. Women use tranquilizer and sleeping pill is bound up with the sort of troubles, worry, and pain they experience in dealing with emotional, physical, and bodily process, most visible displayed in the domestic realm and the private space of gender relations. Many aspects remain to be known in relation with the different use that women of all age make of this kind of drugs as tranquilizer, and the use of pharmaceutical for non-medical purposes is considered globally a major emerging problem that needs to be monitored, for example, in Europe. If we move to the set, substance use function in responding to gender experience, and women are often seen as double bad if they take drugs. So sex scenes can be affect the experience of drug uses and of risky behaviors. No? Substance use function in responding to gender experience of trauma, caregiving, poverty, social bonding, inequality, or marginalization. But the thing is that women are often seen as double bad if they take drugs. It's just we are just looking for our reputation, no? In relation with the set, we have to take into account that sex and gender is interacting different levels for explaining the set. Female and male responses to drugs are different. It has been important, for example, to note that female and male responses to alcohol are different, and that female requires less alcohol to become inebriated or to have sustained damage. No? This is because female bodies typically have more fat, water, or few enzymes for breaking down alcohol. But for me, one of the main aspects of sex is stigma. Women have greater stigma when they are using any psychoactive substances, and they have many barriers for acting harm reduction or treatment programs. For example, global evidence suggests that experience of access to needle exchange service are gendered, and that women who inject drugs access needle exchange service differently to men. And stigma was an overwhelming issue affecting women who inject drugs, which also acts as a barrier to their access for needle exchange programs. The social structure that support stigmatizing about women who use drugs or who inject drugs need to be addressed, as well as more local intervention to prevent stigma. But drug and sex cannot be understood without taking into account the setting. In addition to the specific risk factor that women face when using or trafficking drugs, women or people from non-binary genders suffer from structural inequalities that affect them due to their over-participation in caregiving tasks or in the lack of representation in political and economic decision-making. Gender also breaks down in a way range of aspects, but of primary interest are gender relations, gender roles, gender norms, as they affect experimental opportunities in any given social context. Also of interest is gender identity, the one that there is an identification with dominant interpretation of masculinity, femininity, or gender diverse identities such as transgender, non-binary, or other cultural specific gender diverse groups. Has an effect on how one performs gender and is directly related to the pattern of prevalence of substance use. For example, gender minorities status is often aligned with higher prevalence of substance use. The experience of female and male are impacted by gender attitudes and the assignment of gender role and norm, resulting in stereotypes deep congruent with that particular sex. This has global ramifications that include more income inequality for women, less decision-making power of relationships, family, and state apparatus, more unpaid work, and more subjugation via intimate partner violence. The experience of men include more family and political authority, paid work and income, along with suggestion to the criminal violence injured a war experience. In this respect, gender-based violence that is part of the setting where we are living is one of the most egregious manifestations of gender inequality. Nearly 1 in 3 women worldwide has experienced physical and or sexual intimate partner violence, non-partner sexual violence, or both in their lifetime. And gender-based violence also negatively impacts the health and life of millions of people living within lesbian, gay, bisexual, transgender, or intersex communities. Women suffer situations of violence associated with their drug consumption. They are being affected by their participation in the lowest level of the drug trafficking market, and they have fewer possibilities for receiving treatment or benefiting from preventive programs adapted to their needs when they are suffering violence. I would like to finish this presentation with some data for this research that it was published I think it was yesterday or the day before yesterday in Drug Education, Prevention and Policy. In this research, we try to understand how gender-based violence against Andalusia women who were receiving treatment in the Andalusian public network of drug abuse treatment was understood by the professionals who were working in this network. No? So we have conducted a qualitative research. We made discussion groups with professionals from different specialities all around the province of Andalusia that you might know is a region in the south of Spain. Our data show that not all types of violence experienced by women who use drugs are identified by the professionals who work in the field of drug abuse. Androstenedione pervades the drug dependence service and care centers in Andalusia and appears in different forms in our results. The approach to drug abuse has been designed for the substances consumed by men. The space where the treatment takes place are also identified as masculine spaces, and the experience and specific need of women with their caregiving for responsibilities are not taken into account. So, for example, for Andalusian women, the fear of losing the custody of their children and the possibility of not being able to look after the elderly relative are a barrier to access drug abuse treatment. Our findings also indicate that in some cases, the Andalusian public network for the treatment of drug abuse lack of gender perspective. This is in some therapeutic communities where the re-victimization of women by the professionals can occur. Our results show that the presence of men in treatment centers sometimes represent an obstacle to women's recovery. Our data show too how it is necessary to include multiple victimization to engage clients in the treatment process and to help them to learn how to avoid begin victimized in the future. Multiple and complex forms of violence are interviewing with substance use and are identified by all the professionals who say that women are survivors. The two-way relationship between drug consumption and violence is showing our results. Thus, according to the professionals, being a victim of gender-based violence can increase the use of psychoactive substances, while the latter, in turn, make women more vulnerable to gender-based violence. This two-way relationship is also in line with the data of the Council of Europe. Mutatayi et al. Found the same result, and they say that 68% of the women who inject drugs has experienced interpersonal violence in their current or most recent intimate relationship. So just to finish, I think that we have to think, especially when we are doing intervention, what kind of data we are using. Just to highlight that disaggregated data by sex is not always equivalent to indicators with gender sensitive. Gender is so complex because it's in many places around drug use. So particularities in the way of using drugs, stigma, structural barriers, need for innovative research methods, qualitative research, interdisciplinarity to collect the knowledge of the user and the professional involved is needed. So, and with that, just to say many thanks because I think I am on time. Many thanks.
I'd like to thank you, Nuria, for this excellent teaching you have provided us during 15 minutes on gender disparities and women who use drugs. I would say myself, as a long-time addiction medicine doctor, we still need to learn a lot. And this chapter should be part of our education for all health caregivers in addiction medicine. I'm very excited to see the future of your research and these indicators you refer to at the end. Thank you.
So next we have Rita Gatonye, who leads RADAR, a network of women who use drugs in East Africa, and that works for dignity, empowerment, human rights, and equity for women who use drugs. Rita will be joining us virtually. Welcome, Rita.
Sorry, so hello everybody. I hope I'm audible. Can you hear me?
Yes, we can.
Oh, good, good. So hi everyone. Thank you for having me virtually. My name is Rita Gatonye. As Judy has said, I coordinate a network of women and young people who use drugs in Kenya, Uganda, and Tanzania. And I really regret not being able to be there with you all due to visa issues. I mean, there's so much that I'm learning already just by listening to you all in the past 3 days. And I look forward to catching up with all of you and meeting you sometime soon elsewhere. So I'm just going to talk a bit about community responses to gender-based inequities, improving visibility and facilitating access to services and resources, and the kind of work that has been going on in our region with regard to that. Let me just try to hide myself so that I can see the screen better. There we go. Okay. Yes. So, so our organization is called Women in Response to HIV, AIDS, and Drug Addiction. It's a community-led organization of women and young people who use drugs in East Africa, like we said, formed in 2016 and currently with representation in Kenya, Uganda, and Tanzania with the support of the International Network of People Who Use Drugs. Our focus areas include grassroots advocacy, human rights, and harm reduction and drug policy reform, harm reduction education, legal and social support, sexual reproductive health and rights awareness, and capacity development. So when it comes to gender-based inequities, I mean, everything has been said by the brilliant women who have gone before me, but just to reiterate that it's the same problem all over. Of course, harm reduction we know is traditionally centered around the cis male gaze, and that also speaks to the leaving out or the othering of womanhood in all its forms, be it cis women who use drugs, trans women who use drugs, or trans men who use drugs. The conversation around involving them in harm reduction in the conversation has always been at the back burner and continues to be. Of course, there's the issue of gender roles, as Dr. Nuria has just said, and perpetuated stigma towards women who use all kinds of drugs. There's also a lot of hesitancy in acknowledging the need for equitable service provision. So every time we ask for equity, the powers that be will say, no, we are doing equality. And there's no particular reason, according to them, that women should receive any special treatment in their own words. There's also insufficiency of sexual reproductive health services for women and girls and for their children, including legal services. There's gaps in community-led responses to healthcare and drug use, especially in the global south. We don't have many communities leading the effort. And of course, criminalization as the biggest structural barrier to accessing care for people who use drugs and sex workers. So this is just the picture that we all know, and what I was just talking about, that on the left, with my left or your left, is what the powers that be would rather we have. And on the right is what we really need to have, is to be able to have everyone access the same service, even if it means putting a few more, adding a few more steps to some people's ladders. So improving visibility has been top of our agenda in the past 3 years, again, with the support of the lovely women at Input. I honestly think it had to be women doing this, because we'd been trying for many years. But when women came in to empower women, we started seeing a bit of change. So our network specifically has managed to become more visible to government agencies and to international platforms such as this one and others. We've become visible to civil society organizations in our region. Harm reduction partners are now increasingly including us communities as stakeholders and not just silent beneficiaries like we have been expected to be, silent and grateful beneficiaries. So there's also increased visibility of women who use drugs among other drug user activists in the region. So this has helped us to build solidarity, especially in Africa, where we have an informal sort of network of women that can bounce off ideas off of each other and support each other in very many ways. We've also become more visible to society in general, and this is helping with the drug policy reform effort. So that's also something that I can say that the visibility is doing. This is a picture of a candle lighting another candle. I think we all know this statement that a candle loses nothing by lighting another. And I think this is what has been going on. This has been our experience in the past. So communities have lit the candles of other communities, and we now all get to sit at the table, most of us anyway, to sit at the table together and come up with solutions together. And then, so when it comes to facilitating access to services and resources, the visibility, something as simple as visibility can really not be understated, because what it has managed to achieve for us in a very short time is so amazing that I can only imagine what further visibility for women who use drugs across the world can achieve. So far we've had creation of some learning opportunities, capacity building opportunities, innovation, and of course networking. We've had increased access to professional spaces, like the doctors we have here, and we're seeing situations where we are a bit more respected now in matters that affect our lives. So a doctor who previously would not have wanted to speak to me will now call me and ask, what should I do about this and this, or what do you think about this and this? And I think that's really big, not just for our self-esteem, but for the progress of women who use drugs. So we have also had increased access to funding, and of course funding is never going to be enough, especially if we're talking about hepatitis, but we've had increased access to participatory and flexible funding for evidence collection, documentation, advocacy, and really anything else that we feel as women who use drugs is necessary for our health and our progress, such as be it sanitary material, be it some sort of social support. The visibility has allowed us to request for such funding, and in some cases we've been able to get it. So there's also been increased access to services for women who use drugs, increased reporting of gender-based violence cases and issues to do with sexual and reproductive health. This has happened because community systems, so by building community systems, there has been more trust among the community that we can actually do things, that we can actually run programs and make things work. And this has led to situations where women are actually calling in, asking for referrals, asking where to go for services, women who previously had shied away from services, from accessing services completely. So that's also something really brilliant happening. There's increased demand for harm reduction services among all key populations. So before the conversation on intersectionality became big, and before women who use drugs became visible, really visible in our region, everything was siloed. So sex workers were not talking about harm reduction, transgender communities were not talking about harm reduction, but increasingly this year and last year, we are seeing a very high demand for harm reduction services among intersecting people who use drugs. And that's really amazing because more people are willing to access services and to advocate for them. So we also have increased opportunities for collaboration between service providers and communities because of the visibility, meaningful involvement in drug policy reform conversations. So the lawmakers that would normally ignore us now kind of have to listen because they are now aware that there are people out there and our current model is not serving them. While it will take a very long time for things to change, we have managed to get some small wins here and there. And that's again as a result of making women who use drugs visible and telling their stories. So increased knowledge and knowledge sharing, of course, on drug use, harm reduction, and market trends. We've had increased research opportunities, such as from the Global Fund, because of the visibility. So we have participated in research on sex work and drug use and on drug market trends and increased peer-to-peer empowerment. We have a greater ability to hold to account service providers, researchers, as well as governments on global and national commitments and targets. Empowering communities of women and young people who use drugs, increasing abilities for effective advocacy, program delivery and management. There's increased organizing for groups of women who use drugs. So we have new small groups popping up here and there that were led by women who use drugs for women who use drugs. And that's also something very encouraging. And this, of course, leads to stronger networks advancing the cause of harm reduction. So within the harm reduction programs, there's also increasing acknowledgement of social determinants of health as being a cause of problematic drug use for women who use drugs. Yes, the stigma is still there, but the conversation is beginning to take shape about why, not just the what, but the why. So that's also something very encouraging. These are just a few pictures of the work that has been going on. These are some of our people in East Africa. This is the lovely Judy and the former coordinator of the African Network of People Who Use Drugs. And this is also just a picture of the solidarity of communities of people who use drugs. I think we have Nigeria here, we have the Middle East, we have South Africa, and the solidarity that has brought us far enough to begin to have a very real conversation about women who use drugs. And this is also just the same. Some of these people are with you there. I can see Angie, I can see Ahmed. And yes, so in short, I mean, it's not all flowers, but it is very encouraging to see what is possible when visibility of women who use drugs is put at the center and what this can do for access to services. So thank you all for having me virtually, and I look forward to meeting you all soon.
Thank you so much, Rita, and great to see you virtually, if only briefly. But thank you so much also for sharing some of the progress and the increased visibility for women who use drugs in East Africa. I mean, we all know there's still a lot more work to do, but I think it's also, good to take stock as well, and take stock of the progress that has been made, and as you mentioned, the progress that has been made in a short period of time because of networks such as yours. So next, we're moving to the Q&A and discussion section. So I don't see a sea of hands, so maybe if people want to just turn on the microphone and pose your question if you have one. Oh, yes. Oh, okay, sorry, we'll go. There are a sea of hands. I'll go here and then Ernesto, thanks.
Okay, first I would like to express my impression and gratitude for all the speakers for raising these issues and put facts in front of us. Just I'd like to promote for 3 slogans, if you may call them. Women, when they work, when they seek their rights, they should have the slogan, nothing for us without us. Nothing for us without us. Nothing for women without being involved, without women being involved in all steps. Second, we should aim to work with people, not to work for people. To work with people, this means for any plan, for any intervention, women should be a cornerstone. That is what we meant by working with people. I'm applying it for women. The third, let us apply Rifkin's model for community participation. Let us apply the same model for women participation. And I just remove the word community participation and put the word women participation. In Rifkin models, with its 5 arms, the role of women will be needs identification, organization, implementation, monitoring, evaluation, and replanning. So women should not be just satisfied of being partially involved in a program which came from top to bottom. They haven't been involved in it. And the worst program, all of you knows, those programs which are coming from top to bottom. So if any program for empowering women is coming from top to bottom without being from its base point, from its initial point, from starting from need identification, developed, organized, implemented, monitoring, evaluated by women, I don't think it will achieve its target for women. Thank you very much.
Yes, totally agree. I don't know if any of the panelists want to add or respond. But yes, I'm in agreement. Ernesto?
Okay, good morning. First of all, I would like to congratulate INSU and Input for the Jude Bryant Award. I think it's really important to push forward young women harm reductionists and activists. It's definitely so needed in our field. Me as a community member also think it's a key component also for people from low middle income countries, as we have learned in this conference to call our southern world countries. So sorry, I wanted to address that and maybe ask Jess, because in fact Jess and I, well, Faris over there, are the only people from Latin America in this conference. And I think it's important to highlight the situation in our region and how the war on drugs have affected us and how affected mainly women. Talking mainly about imprisonment, for example, how many women, mostly in most of the countries in Latin America, more than 60-70% of women incarcerated are for drug offenses, the sexual violence all the way. So I don't want to keep going because I would like Jess, if she could expand a little bit more on the situation of women who use drugs in Latin America.
Okay, thank you. Yes, so as we've seen today, there are definitely some barriers and some factors that will affect women in a different way than men, and sexual diversities as well, when we talk about the violence that we received because of the prohibitionist policies that are still in our country. Latin America has excessive prohibitionist policies, I will say, but there's been a response from the community, feminist movements that have been created because the drug activism spaces were very violent to us. So as a response, we started to organize ourselves, and we started to create what we call, anti-prohibitionist feminism. And from there, we've been able to provide specific responses to women for women. I would like to highlight some of the work that the RENFA is doing in Brazil. The RENFA is the National Network of Anti-Prohibitionist Feminists. And they have been, for me, pioneering that movement in Latin America. They've created even, a specific network that will work with people, with women that have lost their kids because of drug-related crimes. And that's one of the violences that we must highlight. So as mother, and everyone that's a mother can definitely understand how would you feel if you get taken away from your child, and how that can increase the possibility of going into a more complicated type of consumption. So the system, instead of helping us, is making it worse. So the responses need to come from women to women, because we are the ones that are living, that violence in our bodies and in our skin every day. There's also something that I would like to highlight. We have a lot of, violence from the police, especially in Guatemala. There was a specific case of an indigenous woman that was falsely accused of having one cannabis plant in her backyard. And she was taken over to, a police station, and she was a victim of sexual violence while she was being moved over to the police station. And this is happening every day to us in Guatemala, in Latin America, and all around the world. And these are the type of things that we need to make sure people are aware, because it is happening every day. And the responses, again, will need to come from us in order for them to be appropriate, like you said, nothing for us without us. Thank you.
Thanks so much, Jessica. Any other questions or comments for the panelists? Yes, please.
Hi, thanks so much. It was inspiring to listen to all of you so far. So, Yolande Andrews from South Africa, NACOSA Key Pops Program Manager. I think that one thing that I know that Input has been very involved with Sandpit in South Africa in terms of women programs, and I think there's still a long way to go. I know that from our side, we're still struggling to reach women who use drugs and inject drugs in South Africa. We're finding that the male partners are really excluding them from the services, and there's a lot of reasons why that you're all familiar with. But I think what's been critical for us is about the structural programs to respond to the barriers. I mean, the one thing is that we've noticed with our pregnant service users, when they disclose that they're on methadone, they find that there's much more scrutiny of the home situation before they are released with their baby when they give birth in hospitals. We also find that I think one of the things that we want to look at is particular programs addressing partners of these women around GBV and intimate partner violence, especially with our women who are so vulnerable, because most of them remain on the streets, homeless with their male partners, and have very few resources or access to resources. And even in South Africa, it's very unfortunate that many of the places of safety, there's very few places of safety for women, very few places of safety for women with their children, and almost no places of safety for women who identify as users of drugs or injectors of drugs. And so I think that from our side as NACOSA, we'll probably reach out to all of you to look at how we develop particular programs around women who use and inject drugs, and how do we address the structural barriers in our country. Thank you.
Thanks so much. I'm sure. Oh, Nura, of course.
Yeah. I think it's an important thing that we have to take into account is that sometimes it's a connection between gender-based violence and drug use, and so the treatment should be together. For example, in Andalusia, we have now a new protocol that it was just made a few weeks ago for people working in the drug field, for understanding, they will understand gender-based violence, but people working in the gender violence treatment center are going to understand how drug use has some gender on it and how they can manage with people who is using drugs. Because what happened, at least in Andalusia, for example, is that if you are having a problem with your drug use and you need help, and you go to the drug treatment system, you are not going to have any help if you are suffering gender violence, because maybe you have you are having another problem that is not resolved. So we only have one resource now, that is Arcoiris, that is a house in Cordoba, where you can go if you are suffering gender-based violence and you are having a drug problem. So the thing is that it's something really important, and it's something really new, that many things have to be together for some group of women. I don't know what's happening in your country, but at least in Spain, it's something that is now we are starting to discuss, and we try to put the network together. But we know that there are many women who are having problems with gender-based violence, and they don't go to the gender-based violence network because they have a drug problem and they cannot be treating the other, no? So it's something really important, no? To put together different possibilities for treatment, not just in relation with drug, in relation with the other inequalities, no?
Thank you. Linda and then Matt.
Yeah. So thanks very much for this session, and thanks to INSU for having given this space. I think it's really important as a first thing to give visibility to the gender and women in particular. And yeah, because if you don't look at the issue, you won't understand. I think that the next step should be really to start to look at the specific issue. And I'm happy that now we are talking not just about, which are very important issues like maternity, children, but also gender-based violence. And I would like also to see other issues, just not to stereotyping also the women who use drugs. One question, maybe $100 question for Nuria and Rita in particular, but also for the other. What do you think should be the follow-up? How we can continue and make this work more effective and also sustainable? Because now it's like very fashion to talk about these things, but I would like this to be coming, systematic. Thanks.
I think I agree with you that it's important not to stereotypize women. So we always thought about women who use drugs who are pregnant, women who use drugs who have children. No all of them have children, or not all of them are in the. So the thing is that maybe to look to the barriers to the treatment center, for example, or to the harm reduction program, it would be more useful. And those barriers maybe come from stigma, from patriarchy, from inequalities that are around, from your position in your work, your position in your family. For example, in this research in Andalusia, I understood that many times women arrive late to the treatment and in really bad conditions, or they ask for help or for harm reduction late because their families are saying no, because you have to be a good woman, that is going to stigmatize you, don't say anything, just keep going. So we will have more possibilities if we look to the barriers and we broke down those barriers from a gender perspective, putting in there women, non-binary people, women with other intersectional situations that for social class, for disability, for many other things that are going around, and not just talk about women who are mothers or women who are pregnant, because that is going to stigmatize again and to make another victimization of women in general, no? Like a special group, and we are not a special group. We all have inequalities around, no? And are related to roles, to mandates, no? To gender mandates. I think that the point is gender mandates are difficult to put together with drug use or with drug treatments or with harm reduction programs.
Thanks, Noura. I don't know if other panelists want to add something. Yeah?
I think there are a few things that we need to consider. First, yes, gender, a perspective in everything that we do is really important, because you are going to be able to identify barriers. For example, if you're working on treatment for a group of people, you need to really be able to work with a gender-based path in order to identify what are the challenges that a woman is going to face that perhaps a man will not face. What are the challenges that a trans woman is going to face that a cis woman is not going to face? Another thing is we need to not just gender-based perspective, but also, looking at racialized bodies. Because there is also, a difference there is a reason why we have more racialized women living on the streets than a white woman, for example. There is a reason why, and from the feminist theory, this is what we call, intersectionalidad. I don't know how to say that in English. Yeah, that. And also a message to the men here. I think that men have a place in this fight, and but it's not a place of taking over spaces, making the spaces violent, but using your privilege as a male to lift up your female partner voices in order for us to have a space in places where we still cannot get to. So there is a place for men, from my perspective, against, in this fight against violence on women. So just listen to the women around you and make sure that you are lifting their voices up and, being an ally, I would say. Thank you.
Judy, if I might add something.
Oh, I think Matt had his hand up first, and then we'll turn to Ahmed and Noura,
Okay.
I think.
So I just wanted to ask a question, really. Just I remember Jude reflecting back to us as European drug users how our network was very dominated by male leaders, and we always looked to Australia as being this case study of a women's-led national network. And I just wanted to ask you to reflect, Annie, about why was that so different? Why did you manage to achieve such a sort of women's-led, not just a women's groups, but actually a women's-led network as a whole? And then maybe to the next generation of women leaders, what is it that makes drug user networks attractive to women organisers to come forward in and to hold space and to take leadership?
Thanks, Matt. Well, feels like a lifetime ago now. Why did that happen? Yeah, you're right. We always felt, we knew that there was something unique going on in Australia because we would look around the world and the other drug user movements were quite male dominated and there's probably multiple reasons for it. We're just quite feisty women in Australia. we like taking up our space, and rightly so. But I think, and it is, I'm sort of making a joke about it there, but, it is important, it has been important in Australia for women and other stigmatised and marginalised groups to find their voices and find spaces and create safe spaces to have a voice. So part of it is sort of a wider cultural kind of context. I think also some of it is the women who were involved. So for my own part, I came from the student union movement. I was a women's officer on student campuses before I became involved in the drug users movement. So in the late 80s, I was at university the first time around and was a women's officer on campus. And not only did that, and I was doing gender studies, the very first gender studies course that was in Australia. And so that framed up my thinking in terms of the work I was doing and how I approach things. But I also, as a woman who was an injecting drug user and on methadone and had my own background in sex work and stuff, I experienced a lot of stigma and discrimination from other women and feminists, actually. And so that really made me think about who just thought I should be abstinent, and that was the problem, the drugs were the problem. And so it's a long way to answer your question, but I think there were other women at AVIL and in the user networks at the state, territorial, provincial kind of levels that also had their own journeys that they brought, both from some coming as feminists, but also then as we worked together, we lifted each other up and learnt from each other. So there's sort of not one answer. Sorry, I know that's a bit of a ramble, but it's early and I wasn't expecting the question. But it's something I think that is worth thinking about more because, it's not something I think we've ever stopped. And I'll just finish by saying that that's one of the issues I think that the drug users movement globally faces, that we're so busy doing. We're so busy just trying to survive, stay alive as organisations and do the work with our communities that we don't very often get a chance to stop and think about why things have happened the way they have. It's quite a privilege to get that time, but we need to do more of it because there's learnings to be had there for sure.
Thanks so much, Annie. And that was a great question. So we're just coming to the end of this session, but I just want to turn to Ahmed. I think we just have a few more minutes if you want to pose your question. I don't want to silence you.
No. Thanks, Judy. My question was actually just for the East Africa presentation done by Rita, understanding that that is the region that has high male chauvinism and masculinity, and now in the perspective of drug use, how do they manage the chauvinism aspect, especially from the same community of the people who use drugs, because that is, we know the young people in drug use and women normally suffer in the hands of masculinity. Secondly, maybe the other question, as a leader of the movement, do they have allies and affiliates in the grassroots that speaks the voice of the women that are so empowered to say that even them today can be posted somewhere? And I also believe that in their country, the country that she is, that is Kenya, the grand cycle of a global fund has been submitted. As women, have they pledged their case, and do they have a surety that we are going to have a women-led service provision in Kenya? Thank you, and over. Yeah.
Thanks. I'm not sure if Rita is still online.
I am. I don't know if you can hear me. No?
So yes, Rita, did you hear the question? I think it was about allies and partners and the GC7 funding request. We have.
Yes, I did, and Ahmed is very good at asking me questions, some of which he knows the answer to because we work together, but it's very good to share the information as well. So I'll start with the last question. Of course, the Global Fund writing process, of course, Global Fund is focusing on health and equity in low and middle income countries, but it's still very difficult to get some government partners to understand why issues of women and drug use should be funded inside, inside, separate from, and within the general drug user program. But yes, we did manage to put in our budget service provision led by, focused on and led by the community of women who use drugs. We don't know how that will look because at the end of the day, it's not up to us, but we did manage to fight and put it in there. Your other question about East Africa being the hub of male chauvinism, I think, was it Jess who also touched on that? And I really love what Jess said about male engagement, which is something we have tried to do as well. Of course, it's not as easy as we would like it to be. And we have to use very many innovative strategies, including, that look at culture, that look at background, that look at the future activists and how they will be able to navigate that space. So Jess said, and I hope it's Jess, I don't remember very well, but Jess said, involve the men. The men themselves should be the ones to push, should be pushing as hard for the feminist agenda as the women are. I come from a community where we were originally matriarchal, so my answer would just be flood the system with women of integrity, like you have at INSU, like you have in Australia, like you have at INPUT. Just flood the system with women that, that have the good fight at heart. But then it's also a balance of advocacy and activism. So know when to shout, know when to play your role as a good woman, if only to get a leg in and change the system from within. So it's a delicate balance. It's a long process, but we do have allies at the grassroots level, and we are committed to the long fight.
Excellent, Rita. Okay, so we're a bit over time. Wanted to thank the panelists so much for their contributions for this session, and also, thanks to INSU also for creating this space as well. I think from the panel, I think the key point that came out to me as well is for women who use drugs, it has to be more than having a seat at the table, but also ensuring that, people are coming to us for solutions as well. Because, listening to people most affected will ensure that, whatever is designed will, ensure its successful implementation. So I'll turn over to Erica for the second session.
Yes, it's my privilege to continue sharing the session. Actually, we will be now touching on two of the most important health harms of drug use related to blood-borne infections, being hepatitis C and HIV. And for this, we will be receiving, he's already here, Professor Jason Grebley, which you all know very well. He's the head of Hepatitis C and Drug Use Group in the Viral Hepatitis Clinic Research Program at the Curie Institute in Sydney. He's the president of INSU, and I would say to me also, he is a very strong voice in the field. He will be talking to us about a national program to scale up decentralized hepatitis C virus point-of-care testing and treatment in Australia.
Don't start my time yet. So I just have one thing to quickly say. So first of all, just massive thanks to INPUT to Judy and Annie for the Jude Byrne Award winners. Jude was a friend, collaborator, and a mentor for me in terms of working with people who use drugs, and just like to congratulate Kira and Jessica. I think it's been an amazing initiative, and I really appreciate it. The second thing I wanted to, thanks. This is a really important area, the morning, and I actually just want to turn it over to Emma Day, who's the executive director of INSU, just because she wants to tell people something or ask a question and didn't get a chance to, so.
Oh, thanks, Jason. Very quickly. Firstly, a massive thank you to the panel. Really important topic, and we've been so pleased to be able to include a Women Who Use Drugs focus on the conference this year and hope to continue to do that. INSU are looking at ways that we can support existing efforts in the space and contribute to work. So if anyone has any particular ideas or is interested in collaborating on anything, please come and chat to us. Thank you.
Great, thanks so much, Emma. And thanks, and sorry to have stolen that couple of minutes, but I just think it's important, and we really want to encourage people to come through in ways that we can facilitate networking and coming together and knowledge translation. So, okay, on to the presentation now. So before I begin, in Australia, we tend to acknowledge the traditional custodians of the lands on which the work that we do, and so I would like to acknowledge the traditional custodians of the lands on which this work was done, and pay my respects, and also to other people that are at the conference, and pay my respects to elders past and present, and also acknowledge and pay respects to people with living and lived experiences, and the lives that have been lost to punitive drug policies. So without further ado, I'm going to speak a little bit about a national program to scale up a decentralized point-of-care testing and treatment in Australia. Here is my disclosures. Okay, further acknowledgements. This is a massive program of greater than 150 collaborators across the country. I won't specifically name them all. I do need to thank the Commonwealth Government Department of Health, who funds this work, and also my close collaborators, Sue Matthews and Corey Marcus at the International Center for Point-of-Care Testing at Flinders University, who all of the service providers, many of whom are in this room, this work wouldn't be able to be done. All right, so we've heard a little bit about fingerstick testing for hepatitis C for detecting current infection. Jordan Feld gave us a fantastic talk about this yesterday. For those that you don't know, it's a fingerstick of blood into a mini microvet collection tube. Minivet collection tube, sorry. This is what the cartridge looks at. This is the Cepheid GeneXpert HCV RNA fingerstick test. This is what the platform looks like. And essentially, we can now have a test result in about an hour. In Australia and Europe, the approval of this assay has really been a game changer, enabling us to detect active or current hep C infection in an hour. And it enables diagnosis and treatment in a single visit, which allows us to also increase testing acceptability and reduces loss to follow-up. It's a little mini lab, so it's very good technical accuracy as well. We're really fortunate. Another person I need to thank and acknowledge is Professor Rebecca Guy. Her program set up a point-of-care testing program in remote and rural and regional Aboriginal community-controlled health organizations for chlamydia, gonorrhea, and trichomonas testing. And then during the COVID pandemic, they also expanded this network to include COVID point-of-care testing, and now have expanded to respiratory testing and HPV testing. So we were really able to use this existing framework to be able to leverage it and really hit the ground running with the point-of-care program for hepatitis C. So this is an observational study. Participants were recruited from sites in 7 of the 8 states and territories in Australia, and includes a range of different healthcare services, so drug treatment clinics, needle syringe programs, prisons, mental health, mobile outreach models, homelessness services, and Aboriginal community-controlled health organizations. Participants were enrolled between January 2022 and August 30th, 2023, so as of last month. The data is in real time, so it allows us to provide information quite quickly. We've now also done high-intensity testing campaigns in 14 prisons, and just a massive shout-out to Mim O'Flynn and Joss O'Lone, who I know who are here, and Mim presented yesterday, for those that you were able to see it. They're just an absolute force to be reckoned with, and a massive thanks to all of them and the collaborations with them. We've also done some work in New South Wales, and there's people from New South Wales here as well, and so to thank them for their efforts, and also from South Australia. Inclusion criteria is pretty broad, greater than 18 years of age. Essentially, anyone who's at risk of HCV or attending a service that provides care for people at risk of HCV are eligible for enrollment. So the program includes standard operating procedures, logistics, deployment, setup of the point-of-care testing platforms, an operator training program that's run by the International Center for Point-of-Care Testing at Flinders University. Here's some of the materials, so sort of line art, very easy to use. And so far, and this is probably a bit even old, but 218 operators have now received point-of-care testing training. There's a quality assurance program that's run in collaboration with the National Reference Lab, so this includes twice yearly blinded samples and once a month unblinded samples to test operator competency and to make sure that the right test, the patient's getting the right result for the right test. There's an IT connectivity system so that all of the results from the GeneXpert platforms are able to be in real time, come into the research database, but also can be sent back into the patient medical records and can also be sent to the state health departments for mandatory notification of infections. There's a research evaluation framework that's been built around the program, and so we've been evaluating, and evaluation is ongoing and in real time. Just a little bit more information. Initially, we started off with a triage testing approach. So essentially, everyone in settings where there was a high HCV antibody prevalence, and we define this as greater than 15%. If you were at Jordan's talk yesterday, further health economic work that we've done actually suggests that if the antibody prevalence is below 75%, it really makes sense to probably be doing an antibody test to screen and then a reflex RNA test for current infection in people who are antibody positive. But anyways, we started off this way, we've now removed it, but immediate RNA testing was performed in these high prevalence settings, and then in lower prevalence settings, HCV antibody testing with reflex RNA testing. And also, we've now moved to people who self-report that they have current infection or they've received treatment. You just go immediately to point-of-care RNA testing. The point-of-care antibody test that we're using is the 2 tests, so the HCV BioLine, negative result in 20 minutes, a positive result in 5 minutes, and the INSTI HCV test, which actually has it's a point-of-care antibody test with a result in 1 minute. So pretty impressive. Neither of these were approved by our Therapeutics Goods Administration, so this is another reason why you'll see that we actually have high Hep C RNA testing, point-of-care testing, because we initially had to use the funding that we had for the RNA testing, and we couldn't use it for antibody testing. The RNA testing that we're using is the Expert HCV viral load fingerstick assay by Cepheid, either GeneXpert 2 or 4 platforms, with the time to result in about an hour. And that test is approved by the Therapeutics Goods Administration. People who have current Hep C can then also receive point-of-care HIV testing and point-of-care hepatitis B surface antigen testing to rule those out as co-infections and to guide management. We have in the community, so the community and prison are slightly different in terms of the data collection. In the community, the HCV antibody testing is captured through REDCap, which is a database software. HCV RNA testing is through this real-time middleware software called ONDAS. Behavioral survey is collected through REDCap, and also HCV treatment, which is collected through medical chart review. The other interesting thing is that every person consents to linkage to administrative databases, so we can link to hospitalizations, drug treatment, incarceration. So it'll allow us to compare, moving forward, people who have and haven't received point-of-care testing within the program and look at treatment uptakes in those groups. Prison data collection is slightly more lower intensity. Their HCV RNA testing is done through this middleware software, and we collect treatment by medical chart review with no patient survey. It's just too much going on in the prison to be trying to implement survey collection. Okay, here's the outcomes. I won't run these through in detail. I'll just run through them as I go. So this is the number of sites and point-of-care tests up to last month. So we've now got 74 sites enrolled. This includes 21 prison sites. And it's interesting because some of these sites are going around to multiple locations. So it's actually, we've tested at 332 different clinics or locations so far. And we've now, this is a bit old, we've actually almost hit 15,000 tests, but as of last month, 13,689 tests. As I mentioned, the majority are RNA just because of this limitation, but we are starting to push up the antibody testing because it's a more cost-effective approach. Of the 11,853 people tested, 39% received testing in the community and 61% in the prison. In the community, the Hep C prevalence of current infection is 10%, and in the prison, 16%. Treatment uptake, so overall 1,660 people with current Hep C infection were identified. So the overall treatment uptake was 71% overall and 86% in prison. And this is amazing considering clinical trial we did in a controlled setting showed a treatment uptake of 93%. So achieving real world uptake comparable. And actually, this is a bit deceiving because what we're doing is looking at treatment uptake at 12 weeks post-testing. So you actually have to remove the people that haven't reached 12 weeks yet. So if you remove those people, the evaluable population is actually 1,296. So the treatment uptake is actually even higher. So it's 79% in those that have reached the 12-week mark. Slightly lower treatment uptake in the community, and I think we need to address this and I'll show you some data of what factors are associated with that. But again, even higher treatment uptake in the prison when you take those that haven't reached that 12-week mark out, so 89%. So pretty remarkable. This is just looking at the overall numbers of people treated in Australia over the past several quarters. This program is now makes up 9% of all of the Hep C treatment in Australia. So we should start to see potentially an impact on both testing and treatment. In New South Wales, the state where Sydney is in, where I live, we started a little bit later, but we can see that now about 9% of the treatments are occurring through the program. But if you look at a state like Queensland, where the program's been running for quite some time, nearly 25% of all of the treatment is now coming through the program. Again, massive shout out to the Combi Clinic, MIM and JOS. I think they can contribute about 50% of all of the testing in the program. So really, really appreciate their efforts. I know this is a somewhat busy slide, but I'll try to run through it quite quickly. What this is looking at is factors associated with Hep C treatment uptake. So looking at characteristics that might predict lower or higher treatment uptake. And the key thing I just want to note is that there's not a lot of difference in terms of treatment uptake by gender, Aboriginal identity, homelessness, prison. People who had ever received OAT but opioid agonist treatment but are not currently receiving it, twofold more likely to initiate treatment, so 67% compared to 49%. People who inject greater than daily in the past month, about a half-fold less likely to initiate treatment, so 43% versus 60%. And if you look at the site type, it's really, treatment uptake is lower in the sites that are providing testing in needle and syringe programs versus drug treatment clinics. So we'll still look at some of this data and try to understand what factors, and I think looking at systemic factors that might be influencing treatment uptake is important in the community because we really need to bring that treatment uptake up, although 52% is still pretty good at 3 months. In terms of program challenges, so ethics and regulatory requirements, it's been extensive training. There's a lot of training to get a program up like this up and running. This isn't, it's not just plug and play. Lots of paperwork, survey, data entry. So again, massive thanks to all of the sites who put all this effort in. The connectivity solutions, I probably make it sound like we've sorted out more than we have. Still need further support to get that all nailed down, but it is coming. I think a critical component is that the program funding does not include staffing costs, and this is a major limitation, and we need to use some of the cost effectiveness data to advocate for increased programmatic funding for these sites. And not having this antibody test has been a massive issue. Successes, look, everyone is on board the bus. It's been so energizing, all of the people involved, and so it's been exciting. We have improved the consent. The Aboriginal Governance Committee actually said to us that we're not going to accept this is way too long. So we actually used that to go back to ethics to allow for verbal consent, which was fantastic. The training has reduced the proportion of error in invalid tests. The work by Corey Marcus shows that in about 5 to 6 weeks, we can get an inexperienced operator up to the same level as an experienced operator. Quality assurance of the program is critical. I know it's a lot of work, but ensures that the patient gets the right result for the right test. Point of care testing has definitely improved access to people with poor venous access. And the prison-led initiatives, I didn't mention, but we've, again, MIM presented yesterday, these high-intensity testing campaigns. You go in, test for 5 to 9 days, screen 700, 800, 900 people, and are able to get really high treatment uptake, should facilitate elimination, and the UK has shown this as well. And community-led testing models have been absolutely essential. Some of our best point-of-care testing operators are the peers that we've been training, and so this is really important. And work led by people like NUA and other community-led organizations have shown peer-led mobile testing models are really quite effective. Okay, so just in conclusion, the National Point of Care Testing Program has been able to leverage other existing point of care programs to quickly scale up HCV testing at a range of sites nationally. The on-site testing has led to higher treatment uptake, although there has been lower uptake in the community compared to the prisons. And then in the community, current OAT was associated with increased treatment uptake, greater than daily injecting in the last month, and testing and treatment at needle syringe programs were associated with decreased treatment uptake. Just really quickly, because I know I'm running low on time, plans will implement point-of-care testing more broadly, increased efforts in the prisons. Some important components is mathematical modeling, cost effectiveness, cost benefit, and budget impact analysis to make the investment case to the funders to provide programmatic funding, and we're doing some of this work in collaboration with Peter and Zoe Ward at the University of Bristol. This investment case is critical, and also some implementation science work in collaboration with Guillaume Fontaine and others to look at what works and why. And we really need the other bits in terms of facilitating capacity for sustainability. Here's some photos. Again, massive thanks to everyone, big team. And one last thing really quickly, the Kirby team, many of whom are here, who do all the hard work on the ground: David Silk, Simon Common, Stephanie Davey, Samira Hushar, Rebecca Henry, Maria Martinez. Danica is here as well. Anyways, everyone, Elise too, thank you so much, and the team at Flinders, and thank you so much for your time.
Thank you, Jason, for sharing this massive piece of work that is being done in Australia. Bravo. Unfortunately, we don't have time for any questions, and I would like to welcome our last speaker, Professor Peter Vickerman, who is working in the field of infectious diseases modeling and will be talking to us about HIV treatment outcomes among people who inject drugs, a global systematic review and meta-analysis.
Hello all. So today I'll be presenting a systematic review we've been involved in the last year and a half. So this has been done by our group, but led by Kennedy Mutai, but unfortunately he wasn't available to attend the conference because of visa problems, which I think we've heard a number of times throughout the conference. So this systematic review is focused on HIV treatment outcomes amongst people who inject drugs. So we all know that HIV treatment dramatically reduces the morbidity and mortality of people that are living with HIV. And it can also reduce the infectivity of people to reduce transmission to others. For people who inject drugs, existing systematic reviews have considered the coverage of HIV treatment amongst this group, the coverage ranging from lows of about 20% in sub-Saharan Africa to over 75% in the Australasian region in 2021. However, data on treatment outcomes amongst people who inject drugs has not been synthesized. And this is important for evaluating the success of treatment programs in this group and for tailoring interventions to tackle any deficiencies or gaps that there are. So we undertook a systematic review and meta-analysis to synthesize global data amongst people who inject drugs on the retention on HIV treatment and levels of viral suppression. And importantly, we also wanted to compare the outcomes amongst people who inject drugs with other population groups to see whether they achieve similar levels of retention and similar levels of viral suppression. So the primary outcomes were retention on HIV treatment amongst people who inject drugs, and for viral suppression we looked at two outcomes: either viral suppression for people who inject drugs who are on HIV treatment, or viral suppression amongst people who inject drugs who are living with HIV. The secondary outcome was effect measures which were estimated from within studies, such as odds ratios, for how the primary outcomes of retention or viral suppression differed between people who inject drugs and other population groups. So we used standard methods for the systematic review. We searched standard databases between 2010 and 2021. We double-screened titles and abstract, and 2 researchers undertook the full text review and data extraction. So, for both retention and levels of viral suppression, there are differences in the measures used across studies. So for retention, people can use different time spans over which they measure retention on HIV treatment. So what we did is we converted measures over different time spans to get a standard estimate over a 12-month retention period. And this assumed that retention was rate was exponential. For the proportions virally suppressed, we converted thresholds that used a different viral load threshold to a standard less than 1,000 copies per milliliter. And then we pooled estimates using random effects meta-analyses. So, we identified overall 133 studies that met the inclusion criteria. These studies were published on average median year in 2017 with a range between 2011 and 2021. We identified 36 studies with data on retention on HIV treatment from 15 countries, with 53% of those countries being high income. We identified 116 studies with data on viral suppression for people who inject drugs, and these were from 35 countries, with 60% of those countries being high income. Some of the studies looked at both outcomes. So in terms of retention, we found that 2/3 of people who inject drugs were retained on HIV treatment after 12 months across all the studies that we had. We found that retention was potentially lower in Eastern Europe at an estimated 50% after 12 months. And importantly, in those studies where they compared people who inject drugs with other groups in terms of retention on HIV treatment, we found that retention rate was 40% lower amongst people who inject drugs compared to heterosexual men. However, we did not find a significant difference in retention rates compared to the general population or sex workers, although there was a signal potentially lower retention in people who inject drugs compared to the general population. In terms of viral suppression amongst people who inject drugs living with HIV, so this includes people on ART and people not on ART, we found 1/3 of people who inject drugs were living with HIV were virally suppressed. And this was potentially lower in Central Asia, and otherwise in some other regions we had sparse data. When we considered people who inject drugs on HIV treatment, we found that 1/2 of them were virally suppressed, and that this was potentially lower, although this wasn't a significant difference, in Eastern Europe and North America, and again we had sparse data from some regions. When we compared levels of viral suppression amongst people who inject drugs to other groups, we found that viral suppression amongst people who inject drugs living with HIV was 40% lower than the general population, and also than heterosexual men. We also found that viral suppression amongst people who inject drugs on HIV treatment was 43 to 50% lower than amongst the general population or heterosexual men. And it's also important to emphasize here that there was quite a lot of studies that fed into these estimates, at least 26 studies in any of those estimates. So, in conclusion, to our knowledge, this is the first global systematic review considering the retention of people who inject drugs on HIV treatment and levels of viral suppression amongst this group. We identified 133 studies from a large number of countries, but there was a preponderance of studies from high-income settings at 55%. I think the most important finding is that we found that retention on HIV treatment and levels of viral suppression amongst people who inject drugs was suboptimal, up to 50% lower than other population groups. This highlights that focused interventions are needed to improve HIV treatment outcomes amongst people who inject drugs. This should include integrated services and a scale-up of those services. It's also likely that stigma and discrimination may play a role in reducing levels of HIV treatment retention and outcomes amongst this group, and that this should be evaluated and reduced. I think it's also important that we need to more routinely collect data on HIV treatment and their outcomes amongst people who inject drugs, so we can get a better idea of how the cascade looks for this group and whether there's any gaps or that need to be acted on, and also for monitoring progress for reducing those gaps. And this data is especially needed in lower middle income countries where there's a reduced amount of data in this study. Thank you. I'd like to acknowledge Kennedy especially, seeing he's done most of the work in this, but also the other co-authors who've spent a lot of time on this review and the funding that Kennedy received to do his PhD. Thank you very much.
Thank you very much for this great presentation. As you were really sticking to time perfectly, there is room for one burning question. If somebody has a question to share with us.
Up there.
Yes, please.
Hi, thank you very much. This was a wonderful presentation. Over the last few days, and again today, I'm struck by the real heterogeneity of the drug supply across the globe. And I'm just curious, when you're doing these large meta-analyses, if you've thought about a way to kind of account for that, given that the sort of the uptake among people who use drugs in things like HIV care or Hep C treatment may be so greatly influenced by those, that heterogeneity.
So when you say heterogeneity in drug supply, you mean for HIV treatment drugs, or?
No, sorry, I meant like heroin versus fentanyl, crack cocaine, what people are injecting, how the drug supply changes, and how the needs of the population are so widely variable.
So it's definitely something that I would like to consider to see whether there's other predictors of reduced levels of retention or reduced viral loads, but we haven't looked at that in the analysis so far. I'm not sure whether we will have the power to do so, but I'm not sure. Maybe other co-authors could say something on that. Right in the top corner.
Thanks, Peter. Great presentation. Were you able to look at OST coverage or drug treatment coverage amongst this population, whether that made a difference?
We did extract data on that. I haven't got those results in this presentation. Jack, do you know whether he's shaking his head? Anyone else?
Thank you very much for the questions. And for us to respect time, I would say we will conclude this marvelous plenary session touching on gender, touching on HIV, hepatitis C, and people who use drugs. Thank you very much. It was excellent.